Well, hello and welcome to the CSF November monthly podcast. And this month, two papers have been uploaded to the CSF website, and I'm going to review both of these papers for you today. It's been quite an interesting time in the field, particularly of JAK kinase inhibition. And the first paper we're going to discuss is the efficacy of baricitinib in combination with methotrexate and concomitant CS-DMARDs. And the principal author here is Professor Ronald van Vollenhoven from the Amsterdam Rheumatology and Immunology Center. Well, the background here is probably well known to most of you. Methotrexate is, of course, our anchor drug. It's prescribed to most patients with rheumatoid, and concomitant CS-DMARDs and or corticosteroids may be added, particularly sulfasalazine and hydroxychloroquine. Now, this was a study that examined the efficacy and safety of baricitinib in two arms, one arm with or without corticosteroids, and one arm with methotrexate only, methotrexate plus CS-DMARDs, or CS-DMARDs alone. The baseline characteristics, adverse reactions, as you would expect, were all evaluated according to normal parameters. So the data were pooled from two phase 3 studies. Remember RA-BEAM, methotrexate inadequate responder patients randomized to placebo, baricitinib 4 milligrams or adalimumab 40 milligrams, or from RA-BUILD, which was CS-DMARD inadequate responder patients randomized to placebo or 2 doses of baricitinib, 2 or 4 milligrams. The endpoints analysed in these studies, primaries were proportion of patients with an ACR20 response and the proportion of patients with LDA as measured by CDAI less than or equal to 10 at week 12. And a whole variety of other endpoints were reported, including the ACR50-70 response rates, percentage of patients with an SI less than or equal to 11, less than or equal to 13.3, CDAI less than or equal to 2.8, DAS28 measures, HAQ-DI, ULR responses of good or good and moderate response, and also changes from baseline to week 12 for HAQ-DI, DAS28, high sensitivity CRP, CDAI, SDAI. So a whole range of secondary outcomes giving us a sense of what happened to these populations. But recall, it's a pooled analysis. And the key results that you need to take home from this, well, I think quite importantly for us, the corticosteroid treatment group showed no significant interactions with baricitinib 4 milligrams or placebo. In terms of efficacy, the odds ratio favoured the baricitinib groups over placebo for ACR20 and the CDAI less than or equal to 10 outcome. Adverse events rates were similar regardless of methotrexate and or CS-DMARDs used for both placebo and baricitinib. The SAEs were numerically higher for the placebo patients on corticosteroid compared to the other groups, and discontinuation rates were higher for corticosteroid users in the baricitinib group. So what do we conclude here? Well, baricitinib showed efficacy regardless of concomitant conventional synthetic DMARDs or corticosteroids. There were no real safety concerns. I think we're all very familiar with the vigilance required in patients taking corticosteroids. And when we think about how we're likely to use baricitinib in treatment, this just gives us a new depth of information. I think it's very important to recall that these kinds of revised post-hoc analysis should be taken just as that. They give us further information to inform our practice rather than defining the true primary placebo versus active drug, which are the registration phase 3 trials. Now, the second study I want to bring to your attention this month is the analysis from Jeff Curtis and his colleagues looking at the herpes zoster risk for patients who are receiving tofacitinib. Tofacitinib is a medicine that works very well in rheumatoid arthritis. It's an inhibitor of particularly JAK1 and JAK3. We've known for some time that the rate of herpes zoster is 2 to 3-fold greater in the recipients of tofacitinib as compared with other biologics and targeted therapies. This particular study evaluated the zoster risk in first initiation tofacitinib users, and importantly was looking at users taking a concomitant glucocorticoids, methotrexate, glucocorticoids and methotrexate, or none of the above. This was market scan and Medicare data. They were used to identify 8,030 RA patients initiating TOFA for the first time. And the risk of herpes zoster in TOFA users with and without concomitant methotrexate and glucocorticoids was calculated using Cox regression. The key study outcome here was the diagnosis of herpes zoster by a physician with antiviral drug use within 7 days. So that's a pretty specific definition and means that we may be missing cases when you think about it. So 8,030 RA patients contributed 5,811 person years to the analysis. There were few clinically meaningful differences in the demographics between the groups, a total of 222 cases of herpes zoster being observed. The rate of zoster in new TOFA users in the absence of glucocorticoid use was 3 to 4 per 100 person years, and this is roughly double the rate of herpes zoster in patients exposed to TNF inhibitors. After multivariate adjustment, using TOFA monotherapy as the reference, exposure to glucocorticoids approximately doubled the hazard risk, but there was no really clear increased risk associated with concomitant methotrexate use. So what do we conclude from this? Well, in people taking tofacitinib, exposure to glucocorticoids roughly doubled the incidence rate for herpes zoster, so vigilance is required. Methotrexate exposure confers no obvious additional risk according to this study. Younger age, male, sex, and vaccination with a live virus zoster vaccine were all associated with a lower risk for herpes zoster. And this may suggest a role for newer vaccination strategies in at-risk patients. And of course, we do have new zoster vaccines coming online or already with you in clinical practice, which will further develop the possibilities. Well, that's all I've got to say. Please don't forget that all the content discussed in this podcast is available in a detailed slide format, and you have to go to the publications section of our website, cytokinesignaling.com. And please subscribe to our podcast channel. Let us know what you think. Review the podcast and send us your ideas and suggestions as to what we could do that would better serve your needs. Thanks ever so much for your attention. I do hope this is helpful to you in your clinical practice, and good luck in treating our patients. Thanks very much indeed.